Good afternoon, everybody. Thank you for joining us for what is going to be our last session of this 3-day event. I will just wait a minute or so just for people to carry on joining, and we'll get started after that. So I will just wait a minute or so. But thank you for joining us. If you want to say hello in the chat, feel free. I hope that you've enjoyed the event so far. Good afternoon, Stephen. Hi, Kate. Great. As you can see, I'm joined by our panel members for this afternoon, who I will introduce. Great. Hi, everybody. Oh, you love Hop In. That's great to hear, Anne. Great. Okay, great. I'll get started, and I know people will probably carry on joining us. So good afternoon, everybody. Thank you for joining us for what is our final session of a 3-day event. I hope all the sessions you've attended so far, you've enjoyed. If this is your first session, welcome. This afternoon is our panel session, and it's a question and answer session with the 4 people I've got on screen today, who are patient and public involvement representatives from across the region. And it's great to have you with us. So thank you very much for agreeing to do this today. So I'll introduce you all gradually. I'll first introduce myself. If you weren't here on Monday, I'm Lois Daniels. I'm the Midlands Health Alliance Operations Manager, which is a research collaboration across the region. I've just helped to pull this together for the last 3 days to bring all of the patient and public involvement contributors and professionals together over this kind of region-wide event. So I hope you've enjoyed it. So first we'll start with Margaret. Margaret O'Hara is the PPIE research lead at University Hospitals of Birmingham and has been since 2017. She supports PPI across the full range of research activity at the University Hospitals of Birmingham. Outside of her job, she does patient involvement and advocacy in Hyperemesis Gravidarum and a trustee of UK charities pregnancy sickness support. More recently, her patient advocacy and research involvement experience has expanded to long COVID, and she is a founding member of grassroots patient campaign group, Long COVID Support. So nice to have you with us today, Margaret.
Thanks.
Next, we have Liz Eglinton, who has been kept very busy during her retirement with her patient and public involvement, having been a lay researcher and contributor on a number of projects. On a personal basis, she has a history of cancer, endured 3 major operations, and suffers from a number of chronic health conditions. So again, Liz, thank you for joining us today. Next, we have Andy Warren, who has been involved with PPIE since 2004, and he became a Nottingham University Hospitals Research and Innovation Volunteer in May last year. He's very passionate about encouraging members of the public to become embedded in all aspects of healthcare and has continued with his PPIE activities virtually during the pandemic. Welcome, Andy. And last but by no means least, we have Tony Kelly, who is well known within the type 2 diabetes community for never having taken any medication for the condition and controlling it by using diet and exercise alone for more than 17 years. He has been a diabetes strategic patient partner for NHS Birmingham and Solihull, CCG, since April, and he's a patient expert by experience with 2 universities as a PPI representative. Tony has been doing community-focused health awareness, raising sessions locally, nationally, and internationally for the past 9 years, and he is also one of only 2 public members of the Scientific Advisory Board. Coronavirus Immunology Consortium. So great, again, great to have you, Tony, and thank you for joining us.
Thanks for having me.
No problem. So welcome all, and thank you for your participation. We have had already quite a few questions submitted before today, so I will make my way through them. If any of you feel that you can't answer the questions, don't worry. And we will start with a question about your experience of patient and public involvement and engagement. How has it been during the pandemic, and how has it changed for you? So who would like to start with the answer for that question? Andy?
Yeah, I'll start that one. Good afternoon, everybody. Thank you for joining us. I've been involved, as I said, since 2004 in what I call PPIE, which is PPIE plus the engagement as well. And I think the way I worked as a frontline volunteer in ED since 76 at both Nottingham and Derby. So I'm used to frontline, hands-on mayhem and chaos. Coming with the COVID, it was a bit of a letdown, but then over the time I got involved with virtual meetings to carry on, and I got the opportunity to join Nottingham University Research and Innovation Group as a volunteer. And this group set up a COVID-19 task force of PPI people to get rapidly involved to new projects, so the projects could get off the ground with patient involvement right from the start. Now, I'm the newbie on that team because research up until then, except many years ago, was different to me. But having a group like the COVID-19 task force, which were all virtual members, I don't think any of us have ever met before. And we've survived by that group sort of developing into an amazing combination of going from discussing things that I'd never heard of before, like in genetics and mRNA and DNA and all this sort of stuff, and vaccines and vaccinations and all that. Because as a technical schoolboy, I was never taught biology. It was frowned on to teach biology to men. And so I had a massive learning curve to learn basic. Okay, you pick up the basic biology for being around, but the clever stuff. And I think the combination of the friendliness and informality of the task force, which works as just for Kate's benefit, it's hard working, we're dedicated, we're hard at it, we work strong hours, well, sometimes. And so it's been an amazing combination of one day we could be discussing somebody's having boiled eggs for lunch, right through next to discussing how vaccinations using messenger RNA actually work and how we can do research to sort that point of thing. And then we'll flip back to something else like beekeeping or anything. But it's an amazing group that's kept us all going, I think, through this time. And we've managed to come up with some amazing ideas and suggestions. And so it's just having that, you've got the group to talk, and also you get challenges of learning new topics and new areas. So your brain's getting battered as well as you're getting a bit of sociality back. And I think that's definitely kept me going over the last 12 months.
Thank you, Andy. That's great. Anybody else to add, Margaret?
Yeah, I have a sort of strange perspective on this because I'm coming from being somebody who works in public involvement professionally.
Yeah.
And then getting ill with COVID and being off work and actually then being off work for months and finding myself with this new condition, which we're now calling long COVID. So I've just flipped from being a professional to being a patient again, and a patient with a new human disease that no one's ever heard of. And so that's been interesting from a patient involvement point of view, because there I am now as a person needing research, because obviously you can't do anything without research. The GPs don't know what to do with you, even if they're sympathetic. Nobody knows what to do with you because nobody's dealt with this before. So so I met with other people online in social media. There's a whole big campaign, grassroots movement of people who've got together and gone, actually, I haven't recovered from this. They said it was going to be 2 weeks and I'm still here. What is going on? And then we started pushing for research, and I've been speaking to the NIHR more than I ever did in my actual job, because it's to say, look, we need research. Can you speak to us? Because this is what it's like, and this is what we need. And it really highlighted in a really focused way, in a very, very rapidly, and in the middle of a crisis, why we need patient involvement, and the real risk of not getting the research that we need was, you're sitting at home thinking, am I still going to be here in a year? Like, am I ever going to get better? I really need these researchers to find something to help me, or I'm not going to get my life back. And it's really like right up and personal. And I've been trying to encourage people to get involved in research, and some of them are here actually, and I see somebody in the chat there who I've met on this journey, and I've been trying to get people in to speak to the NIHR, review grants, do stuff, like, because we all need our voices to be heard. So I've had a really interesting pandemic from a public involvement point of view, and not that I would have particularly asked for it, but here we are.
Hello. I'm going to start by saying, and I say anybody in this group who are listening in to take me up on that, I am the world's biggest technophobe. I don't do technology at all. And it started after lockdown, because I do, as you said right at the beginning, Lois, I do on average 150 to 160 community events per year, health and well-being to do with diabetes. I'm retired, and I've been doing that for the last 8 years. June coming now is 9 years. Took early retirement after 30 years. And I go into communities. I firmly believe in this saying, if Muhammad can't go to the mountain must go to Muhammad. And I will start by saying, I don't use the term hard to reach. It is an offensive, insensitive, and somewhat racist term that people have used in the past. We need to move away from that, because I say to people when they say hard to reach, my immediate question is, are they on the Mars, Jupiter, in the rainforest, in the jungle? They're not. So why are we describing any people, whether they be African, Caribbean, Asian, or people with health issues in terms of sight or hearing, hard to reach? So if I can reach them in my voluntary capacity, so can anybody else. So we need to get from behind our ivory towers and behind our desks and go and engage. So that's my starting point. So that stopped at lockdown. So I had to then get used to the idea of the technology. NHS Birmingham and Solihull CCG gave me this super duper laptop, brand new. And then I started to get to understand it with my wife helping and my daughter helping. And I'm now doing community events, health and well-being from Canada, Africa, Jamaica, Dominica, all over the world, places I would like to go to. I have been to a lot of these places before, but now having to do it from the comfort of our home here. And that for me, so I can do 2 or 3 a day. So those listening in, if they want to get in touch to learn more about health and well-being, especially in relation to diabetes, which has featured very high in the whole issue of the COVID-19, then Tony Kelly Diabetes at hotmail.com. And that's what I'm about now, doing it from the comfort of my home. But I can't wait for lockdown to stop for me to go on. I like the personal touch. I like to be with people more than talking to you all like this now. That's me in a nutshell.
Yeah. And I suppose my next question just, sorry, you want to?
Okay. Will you carry on with that and then I'll...
I suppose just following on from that question, it's kind of, and obviously you've explained that things have gone more virtual, you've had to get used to using different platforms, etc. Things have obviously completely changed. I suppose from those experiences, what have you found challenging, or what have you enjoyed about it? So, what are the positives and negatives of the way things have changed for patient and public involvement over the last year?
Tony.
To answer, Liz, yeah?
Oh, well, for the first kind of question, I've been sent the stuff we used to comment on, patient information leaflets and things via email, and that's quite useful. And emails something I've been used to.
Okay.
And the only other thing is this video conference, which is quite a nice learning curve because I wondered how on earth the conference would work. And, you know, concerned about the platform because I'd recently had a Teams meeting, PPG, the GP group practice, we had a meeting and I just couldn't get on with Teams.
Yeah.
Every week we have 5 Zoom meetings a week, so I'm used to Zoom. So I was a bit worried about Hopping being another thing we'd have to download.
Yeah. Oh.
And the fact it worked from the website was fantastic.
Oh, this is cut out, but hopefully she'll be back in a second. Has anybody else got anything to add to that question? You know, I think
the only thing I'd like to add, just to clarify things a bit, is coming this side, it's my sort of first experience of dealing with PPI in a research environment. I mean, all my other prior to that was in primary care and the involvements from GPs and things like that. So there's a subtle, there's a sameness, but there's a subtle difference, if you know what I mean. You know, it's.
I can't see anyone else, and I don't know whether I'm the only one being seen.
Hi, Liz. Can you hear us?
Can
Liz hear?
What to do?
We'll just,
we can hear me. Thank you.
Yeah, we can hear you.
I think I more or less finished that. I find this is an excellent way, and if people got used to it, it's great to be able to have meetings without having to actually travel at the same time. As a PPI with my level of health, it's enjoyable. But I do recognise I do have a lot of computer experience, so it might be easier for me than most people. Thank you.
Thank you, Liz.
Okay.
So the next question is, over the last year...
Can't hear anyone else.
Will you just mute Liz for a minute while we sort her out? We'll sort Liz out and we'll make sure she can hear us again. So over the last year, we've all been conducting involvement virtually and remotely, like we've just been saying. So what are your thoughts on moving back to face-to-face methodology? And how much should we continue to utilise the technologies that we have been using moving forward? So what would you imagine it to be like post-COVID?
Well, I'll start by saying some of the communities that I have been engaged with, and that is even happening in the school setting. My wife was a teacher, primary school teacher. Some people do not have ready access because of socioeconomic factors, because of poverty, etc., to the technology, whether it be the laptop, whether it be the top computer, or whether it even be mobile phone. So we need to be mindful of that. And there's nothing like going back to face, being in a group and being able to interact with people and get a vibe from what's happening. So although the technology is there and we need to embrace it, and we all are trying to do that, I still see room for people being able to see you and engage with you, embrace you, and have a better one-to-one and a group session with you. So there's room for both, but we must not go down the road of being so techie that we forget there are people out there who don't have the equipment, don't have the know-how, don't have the internet connections, which are sometimes in and out and what have you. We need to be mindful that these so-called marginalized or difficult to reach communities who have been, what we would say, in a sense, historically neglected or underrepresented, we need to make sure that we don't go down these routes to such an extent that we forget the very people who need the help the most.
Yeah, definitely. Andy?
I think the future, I hope the future will be a combination. And I hope that people who run the virtual meetings now and are getting very good at it, my boss is a genius at sorting the meetings out. And I think we'll end up, hopefully, with a mixture of face-to-face and virtual. So that way, the people who live close to where you're going or it is travelable can be there, but people who can't travel, seriously ill or people in other countries, and I can think it would be absolutely superb to have a meeting of us where we've got people from various countries around the world, you know, because research projects especially are more and more international. And it'd be great to have PPI reps from other countries that are involved with the research project, just to get a view of how that happens. And I think, I hope it never ever ends up purely virtual video, no speaking. That would be a disaster. But I think the combination will be very difficult to manage. But I think it's the way, really the way forward, you know, and finding out what other people think of, you know, hopefully there'll be some good ideas that we can steal and some ideas, you know, things like that. So, you know, I hope that's the way things go.
Yeah, okay, definitely.
Definitely.
Hi, Liz.
I just want, a lot of the research is collaborative overseas anyway, isn't it? So it is good that we should be able to get PPI from all the studies.
Yeah.
All the countries they're studying. Yeah.
Yeah, definitely. And actually, relating what you just mentioned, Tony, the next question was about how we could engage with communities, especially hard to reach communities, better online. And like you say, you know, a lot of that's been around going to them face to face and engaging with them in person. But, you know, over the last 12 months, how have you engaged with the hard to reach communities, and has it worked? And how can we do that better, do you think?
As I said at the beginning, Lloyd, doing this now 9 years in June, I really love and detest the term hard to reach. Nobody is hard to reach. I know it's something that trips. I sit on a lot of August bodies, and it's something that trips off the tongue of a lot of professional people. Remember, I'm a volunteer. That's my health disclaimer. But I have to say in meetings that I go, when I keep on hearing them say hard to reach, I say, listen, I will say repeatedly, they are not on the moon, Jupiter, Mars, in the rainforest, in the jungle. Don't describe and patronize communities by calling them hard to reach. If you say historically neglected or marginalized or underrepresented, people will come on board more and be more accepting. So we need to be careful of our language, us as professionals, us as lay people, what have you, because we want people to come with us. And the whole issue of seldom heard, one has to question, okay, why are they seldom heard? That's because people aren't listening to them. And COVID-19, I think, has clearly, Lois, brought that home to us, that there are issues of health disparities, racial disparities, health inequalities, racial inequalities, systemic structural racism. That's one thing, without a shadow of a doubt, I can say, and anybody who is wanting to look at stats can say, apart from the comorbidities, there are issues around how are we engaging with communities that are not sitting at the table, which is why I have decided, people said, Tony, you need to be around the table. I asked permission to be on this today. I had to speak to Laura Chapman, who is part of the muscle group that I'm involved with. And I said, I want to see equity, equality, and inclusion. Hence, I don't want to go to any events where I see an all-white panel. Mm-hmm. This is the 21st century we're in. So I actually proactively put myself forward. And that's what I do. And I speak on behalf of a lot of communities who say, Tony, we just want our voices to be heard and people to take on board what we're saying. And people might say, at the end here now, people might say, within the African, Caribbean, Asian community, there's a lot of apathy and inertia. I've been in Britain, born in here, but grew up in Jamaica, 42 years since I've been back. And it's about researchers going out there, picking the brains of people, going and getting their stuff from them and so on. And some not even have the courtesy or the decency to go back and say, here is a lay summary of what we found out about whatever. And that, for me, people say that to me all the time, Tony, they pick our brains. There's a Jamaican saying, we're tired of being tired, because the researchers, the academics, the consultants come out and they say this, say that on the other, and we don't see them again. And now you'll notice lots of grants are being because of COVID-19. And we want to get the African community, the Asian community, the Caribbean community on board. It's going to be a struggle because they have been let down in the past, and that needs to be said loud and clear. We need to be mindful, and that applies to, I do a lot of work with blind people and people with deaf And they ask me so many questions. And I say to the tutors at the colleges I go to, why do the deaf and blind people, they say, nobody engages with them. It's as if they're not here. It's the same sort of thing.
Margaret?
Can I pick up on something that Tony said there? Totally well said on all that. You talk about researchers who don't come back and tell you what happened, you know, close that circle. It's like they kind of, you know, they pick your brains and run off, and they get their paper and you're just left going, well, what was that all about? The Health Research Authority has a transparency agenda at the moment. And so for people that don't know, the Health Research Authority governs ethical approvals for any research in the NHS. So for NHS researchers or any research which involves NHS data or NHS patients, then it must go through the Health Research Authority. And they, in the past couple of years, have been doing a consultation on research transparency, by which they mean telling people that you're about to do the research and keeping them informed and then telling them afterwards. And they have a research transparency strategy on their website, which you can look for, and it tells you that 90% of clinical trials don't tell the participants in the trial what the results were. So it's not even just about communities. I mean, most researchers don't tell anybody that took part what the results were. And the Health Research Authority now is beginning to crack down on that, and it wants to make it compulsory for researchers to deposit a lay summary with the Health Research Authority. And they also want to they also want to highlight to researchers that the extent to which they feed back their previous research result will have a bearing on future approvals. So in other words, if you haven't told the last group of people from your last research study what the results were, we're not going to approve your next one. So it's moving towards that. And I think it does have to come from authorities, and it is an ethical issue. It's an ethical issue to go and use people and then not even treat them like people and tell them what the results are.
That's a really valid point. Yeah, and that sounds like a really good thing for the HRA are doing. So that's really good. Liz, did you put your hand up?
I just wanted to pick up a thing that Tony said, that people need to be listened to. They also, but still, sometimes they're listened to, but still not heard. I've been in a situation, it was a while ago, where we, as a group of PPI, we made a poster for a conference poster at the NEC. We all agreed on it, signed it off, as it were. When we got there, it looked entirely different to what we'd agreed on. You know, yeah. So this was 4 or 5 years ago, but you know, it seems to be a problem. But you know, any tackling of it is better. But sometimes it's too late. But you seem to be the type of guy who makes sure you're heard when you talk.
Oh yes. What I'd like to say as well is, I'd like Margaret, from what she just said, to send us the link or give it to the organizers of this, because I'm involved with a lot of communities, and that's their bugbear. Tony, we're tired of being tired. We find these people rude, impolite. They never come back. They never say anything to us. So I have a list of about 2,000 African, Caribbean, Asian people who at the drop of a hat, I could put their names forward for event. I don't do that anymore. 42 years of living in this country, and they are saying, no, Tony. And another thing is, they need to be remunerated. You can't be going asking people for their time and the resources and the energy and not pay them. And then you have a consultant on the news yesterday or the day before getting £6,000 a day for consultancy work. And you have these people out there, you want to engage with them, look at their health issues, research, etc. And you're not even prepared to give them some traveling and so on. That's issues that need to, and so much money is being doled out. People hear the news and hear what's going on, and they have to ask, what is in it for me? Not just from a health perspective, but from a monetary angle as well. You can't be using people for freeness. Mentality has to go. And I'm speaking on behalf of my communities when I say that.
Well, you're speaking on behalf of everyone, actually.
Thank you.
Thanks, everyone. Okay. So the next question is, What has been the biggest barrier for you in terms of getting involved with patient and public involvement? You know, what has been a problem for you? What stopped you from doing so or made it more difficult for you to get involved? Has there been anything, or have you found it quite easy? You know, what have your experiences been, Margaret?
I think for me, the biggest barrier is sometimes attitudes. And sometimes it's the attitude of the researchers that try to engage with you. And in particular, over the past sort of 10, 11 months, where I've been approached by a lot of people doing a lot of research on COVID, long COVID and so on. Sometimes I can't keep up with it is part of the problem, but also the way that they engage, you have to very quickly, you sort of triage, and I'm sure the others do this as well, you very quickly get a feel for, is this person just going to kind of suck my brains out and run, or is this person here for some kind of relationship and I'm going to get something out of this? And I think so, it's not so much a barrier, but it's just a kind of, you get the measure of them, and then you kind of decide whether they're worth your time almost, and whether they're treating you well. And some researchers may not even be aware that they're doing it, but their approach has to be the right approach, or they'll just put you off and you'll just think, no, I've been here before and it was a waste of time, I'm just not going to bother. And I wonder to what extent we need to speak to researchers about that, and just to say to them, look, you've got to be, everybody should be respectful anyway, but also just be mindful that people have been approached before. It's like what Tony was saying, you know, you get approached before, and then if nothing good comes out of it, then you're just wary of doing it again. And that's about their personality and the way they come across, and within a few meetings you get a feel for it. And I think and for them it may not be, maybe you're getting the wrong impression, but I think researchers have to be very mindful that they must get that first impression right, or you're just not going to engage.
Yeah. And Liz?
Well, early on when I was on a co-applicant, actually, I'd had a very nice warm meeting with the team leader. And the next time I met, she wasn't in the room when I walked into the room, and the team were there in a huddle. They glanced round at me as I came in, and then carried on in the huddle. And had I not been the stubborn type of person I was, I would have said, oh, right, they obviously don't want me, I'm off. And it did stop me from participating as much as I would like to have had, because I felt I was the intruder.
Yeah.
And you know, I to them I wasn't on their level. I don't think they thought. I do have qualifications that makes me more than on their level, but I've got a PhD, research PhD, which I did as a mature student. But you know, very difficult to.
Yeah, definitely.
You know, the shy person in me took over. The
And
polite person.
Sorry, Liz.
That's it.
Okay.
Thanks.
I think there's a couple of things here. One, I want to agree with Tony totally, that if you start something, you should always take the full circle and feedback, no matter whether the feedback is good or bad. You should always complete the circle. And that should be everybody's sort of gold star hanging on the wall of every meeting, every discussion, every conversation. Like, you go into a clinical situation, there should be a complete circle. You know, the problems, the diagnosis, the treatment, and it goes round and you keep that circle. So I think that is critical. I think the other problem is that PPI or PPIE or whatever is not, it's got to be embraced by the clinical staff as well as the research staff. Because a lot of research staff that I around are clinical staff. And until doctors and nurses and pharmacists and radiographers accept that patients are living this situation all their life, and they shouldn't just be considered as ticking a box on a form that says, have you done this meeting well? You've invited the boss and the secretary and, oh, a patient rep. And I think the worst case of this I ever saw was in Nottinghamshire some years ago, when they were looking at a redevelopment of a situation, and they asked for people to feedback and give comments. And then the next thing that appeared was a 16-page glossy brochure printed on 160-gram paper with colour pictures, asking for comments and feedbacks on this. Well, if they've gone to that extent, all the comments and feedback requests was so they could tick the box to say that they'd asked those questions. And I think until that acceptance of the patient and the public involvement right back through clinical work and then research it's never going to be really accepted. And I'm a bit like turning away, that if people start ignoring, then I just start asking leading questions, and until they suddenly wake up that, oh, this guy happens to know what he's talking about. Oh dear, what a shame, we're now in a mess. So I think, we've got to be positive, we've got to be forceful, but we've really, really got to get this embedded across the whole of the health network right from day one, is my thoughts.
I would just add to that, and this is my personal experience, which I then have to say to people: nobody must deny anybody their personal experience. That's their reality. Okay, for me, since lockdown and we've gone virtual, more people seem to know of me and what I do. Yes, I used to do 150 committee engagements per year, but now they're being done virtual. And a week does not pass when somebody doesn't get in touch with me. Oh, would like you to join our this or join that or join. And I said, well, hang on here, I only have a pair of hands. So I'm conscious of burnout. The emphasis now seems to be we need to get more African, Caribbean or Asian people, Black people, as I call them all together, on the various medical research panels and so on. I'm on about 4 and I've cut and said, no, that's enough. So it's about how do the researchers, the clinicians, the academics, go out there and find. There are more Tony Kellys out there. Somebody said, oh, Tony Kelly needs to be cloned. I don't think I need to be cloned. One of me is enough, I think. But no, seriously, there are more people out there who have skills and are able to communicate and about their experience and so on, and able to be part of groups or what have you, and are not backwards in coming forward. But it's how do you get them involved? I sometimes get some involved and so on, and they say, okay, they'll do this piece of research. But there are lots more people out there, some retired, some coming up to retirement, who we need to try and say, okay, let's try and get them on board, because this is the future. We're not going to go back to the 60s or the 70s. We're needing to move with the times. And for me, the diversity angle has to be in there. More African people, more Caribbean people, more Asian people. As I said earlier on, I don't go anywhere, even when we go to watch the opera or we go to watch a performance and so on, we look up the cast beforehand. And if it's a sea of white people, we choose not to go because we're living in a different world altogether. And people say, well, why did you come to the performance last night? And I said, I want to see people who look like me on this stage as well. And my daughter and wife think the same as well. So that's my view on it. And showing some empathy as opposed to sympathy with the whole situation. So we need to branch out and get these people. They are out there, but they need to be approached in the right frame of mind and so on, and take it further forward.
Yeah, that's really valid. And thank you for all of your comments on that. That was really interesting. So the next question is about moving forward again. So if the panel members could pick 3 key areas for PPIE strategy or direction moving forward, what would they be, and what should organisations and PPIE professionals be focusing on moving forward? Andy?
Can I carry on with my last comments here, because this takes me into an area which I think is going to be critical. I personally think that PPIE and all its accoutrement should be part of the undergraduate teaching for doctors, nurses, allied health professionals, right from the word go. And when they first go on a hospital ward in any area, they've got this brain that these patients, if you take the situation, I've got metastatic prostate cancer, I'll admit it. I've had it 2 years now, so I'm currently outliving my 2-year expectation, which is quite good. And I see my consultant every 3 months for 20 minutes. Or if I'm lucky, I see him. If I'm not, I get a video call. But I live with that condition for the other 2,000 whatever minutes, hours there are in the month. And I think a lot of clinical staff forget. They think that, oh, I technically know how to dispense a yellow pill that will do this, but they've got no experience or ideas of how that person has to live with that condition and potentially the outcome of the yellow pill. So I think it should be taught right from the bottom, and before anybody can become a clinical researcher in any area, they should also have to do a refresher on the PPI setup, so that when they start coming out, the first question they ask is, what am I going to research about? Okay, we'll give you that much. The next question is, how do I get a patient group to look at this, A, from the point of view of patients suffering from the XYZ disease, but also from people who can read information sheets, know the population, can get out into the population and get the other groups of people you need to support that. And I think as a sideline to that, that's my prime. I think that should be absolutely written in stone and not happen. The other one is, I think, how is there a situation where, like, if, okay, I've got prostate cancer, so, you know, it's only the male side of my family would be sort of useful. But I think it'd be useful if patients, the right patients, when they see their consultant, would say, have you got friends, family, who might be able to become involved with the research to support you and fellow sufferers in the future? You know, and then you've got probably 2 or 3 people. But if you've got 10,000 people suffering from a disease, if you've got 3 people each, you've got a huge potential market for getting some of those people to be involved in that research, either as patients or to do the other support roles that are just as critical, like reading the documentation that comes out for patients that you need an encyclopedia to read. So I think that's 2 areas that I'd like to really see embedded in the future PPI.
They're really interesting points, Andy, and I really agree with the teaching part. I think that's a really good point. Tony?
I'd add to that, I'd carry Andy's a bit further, because PPIs, as I see them, because I'm sort of fairly new in the whole PPI agenda, they seem to be an afterthought, an add-on or an afterthought. And from what I understand, Andy's saying, osmosis, it should permeate from the start medical school or wherever they're doing their degree or so on, and seep right through. So it's part of the DNA. You think PPI, just as how you know when you get up in the morning, you have to go brush your teeth and comb your hair and so on. It needs to be osmosis seeping right through, more than a tag-on approach. So that for me has to be, so we need to rethink how we do PPI, because even the term PPI, I'm not into acronyms. I like to, if you're going to a community and you talk about PPI or PPIE, straight away they look on you. I've been to lots of meetings when these acronyms trip off the tongues of healthcare professionals. I haven't a clue what, and I will turn to a professional next to me and say, can you tell me what that acronym means? And even the professional next to me says, Tony, to be honest, I don't know, you know, but I'm just sitting here looking intelligent. So that for me is a starter. And another thing is cultural competence. There are some differences in the culture of the African, Caribbean, and Asian people, which I have over a period of time gotten to understand, even within it, which people need to be aware of. You can't have this one-size-fits-all glove. It will not work. For instance, I go to events, and I'll give you a classic example at events, whereby, and people think, well, the Black person isn't engaging. And this happens in doctors' surgeries as well. I go to an event, and I'm going to do a quiz, and I hand out the sheets, and somebody shouts out, I forgot my reading glasses. That person, it's not a matter of they forgot their reading glasses. That person might be in their 70s or 80s. It's nothing to do with their sight failing them. Basically, they are unable to read or write. They have literacy issues here, but they're so embarrassed that they won't say that. And that happens in doctors' surgeries as well, where you're putting the thing in front of them and say, read this, and they look, body language, they look away or so on. You've got to be in tune to these cultural competencies that we're talking about, the food that eat, the body language, etc. If students at medical school and at universities aren't taught at an early age, how passionate some people are in terms of gesticulating and moving their hand. It don't mean that we're getting aggressive or anything. It's our way of being more assertive or so on. You have to go back to culture, back to basics in terms of cultural competence, because what will apply to a white person might not necessarily apply to the African person and might differ from the Asian person. So that for me is part of the whole issue of moving forward. Those are the two that, and then finally, the third one for me is community engagement. I've said it from I started, it permeates, it must from all the way through. Community engagement, community cohesion. You cannot stay in your ivory tower or behind your laptop and expect to just ever so often parachute into a community and then leave and then that's it till another crisis come and you come back 10 months time or a year's time or so on. They'll get fed up. They will just say, go away. Those are my three.
Yeah, that's great. Thank you, Tony. Liz?
Well, first of all, address professionalism, I think. Because to me, professional includes the ability to communicate at a level that's understood by who you're communicating with. Professional, you know, some people think their professionalism is enhanced by using jargon and acronyms, and it's not. I agree with Tony about acronyms, and I'll just quickly tell you. A while ago, I gave a talk to some people, researchers, wanting to research about my experience as a PPI. So I started with quote. Just a bit about my medical history. I've had a right SO and an MD and a CS, a PFR hysterectomy and left SO. I've been diagnosed with CFS and COPD, and a recent MRI suggests SVD. Right, does everyone know all these acronyms? Because as I was going through this, they were all good. So, you know, you need a way to get to them. And pointed out that SVD has 11 different medical meanings.
Wow, yeah.
You know, and this guy who said, oh, I don't know what it means either. I mean, he's wasting his time, isn't he, if you like, because he's not getting the full picture of of the information he's being given.
Yeah.
So, you know.
Very good point. Okay.
But can I do my second one is,
Just
I feel it's the PPIE professionals in their meetings with their researchers to train them, if you like, by calling them out and sussing out their attitudes towards people. Another of my favourite things is when their participants are called subjects. Subjects are lab rats. You know, the monkeys they used to, and the beagles at Fison's in the years gone by. They're subjects. Subjects are experimented on. Humans are participants who participate with study. And a couple of days ago, I was reading a study, and there was a subheading, subjects. This was a study about humans. You know, and to me, that calls out the attitude of the researcher, if they're still calling participants subjects. I think that's my bug.
Thank you, Liz.
Okay.
And
Yeah.
did you want
just a quick sideline. I mean, I worked on frontline in emergency departments for more years than I run, and it's quite interesting. You get notes written by a physician that the orthopods can't read, and the orthopods write stuff that the the pharmacists can't read, and the nursing staff can't read any of them, because the three-letter algorithm, the three letters used mean totally different things in different technologies. So you've not only got the problem of what the hell does it mean anyway, but you got the problem is who wrote it, and does it mean something different? So this is a major problem. And if you think it's bad in medicine, you should get involved with computing. It's horrendous.
Yeah, but
I
computing
just
is
follow-
so life-threatening.
So following up on Liz's point there about subjects, I think this is it's really important in research that not only the people that do PPI, but the people that are actually participating in and going to be recruited into the research are treated as people, because, you know, people have a choice and they don't have to take part in your research. And if your research isn't attractive, then they're not going to do it. And you need to speak to people to understand what people will like or not like about what it is that you're going to do. But I think for that seems like a very transactional type of thing, where it's and we do sometimes speak to researchers on that basis and say, well, if you want to recruit people, if you want your thing to succeed, you're going to have to get people's opinions. But this is very much like I say, transactional. You're going to get something out of this if you do PPI, so you know you'd better do it. But I think I'd like to draw it back to an ethical framework, because I think it's unethical to do health research without doing patient involvement. And it's unethical to do research without first establishing that people want that research. The people who would be the beneficiaries, who are supposedly the beneficiaries of your research, actually want that research, and they want you to do it in that way. And to do it properly, coming back to Tony's point, you can't just parachute in and out. It takes time, and a lot of the researchers that come to us are saying, I'm doing this grant, I've got this grant proposal, and it's due in X weeks or sometimes days, and I need to do PPI. And I think what I would like to say to researchers is, look, if you're thinking about doing research, you need to think long term, and you need to start building relationships now for your grant application next year or in the next 6 months. And it takes time to develop relationship. I mean, any relationship, any human relationship you have takes time to develop. So you've got to be at the point where you have people, you're not about to put in a grant application thinking, oh, I need people, because you've already got those relationships there. And again, with coming back to ethics, because you've built up a relationship with those people, then you wouldn't treat them badly, because, you know, because you're a human being and they're a human being. And I think it has to come back to that, really. And again, we're back to the HRA, and we're back to ethics committees and so on. There was a discussion in the previous session with somebody who's on an ethics review board, and sometimes he said sometimes they ask for more patient involvement. You know, they go back to the researcher and say they need patient involvement. But I think it needs to be flipped around. I think you need to justify if you don't have it. You know, and you should also be justifying why haven't you been speaking to the different types of populations and communities who will be affected by your research? You know, what's your excuse? Because it should just be the default. And if you don't do that, you don't get your grant, you don't get your approvals. And I think it has to be something like that. Some researchers, they're trying their best, but it's systemic as well, because they're sitting within a structure, within a higher education institution or an NHS institution where there isn't an awful lot of support or resourcing for it. So try as they might, they're doing their best, but if it's not resourced, nothing's going to happen. And it's systemic, and it comes from the institutions. And I think, but that has to go to the authorities. The authorities have to lean on the institutions to get them to provide the resource.
I'm just conscious of time. Tony, is it a quick?
I just quickly add to that. We have the Single Equalities Act, and there's something called impact assessments, and those should be built into anybody doing this sort of work. So is it impact assessed? Does it cover disability? Does it cover gender? Does it cover religion, or all the other various characteristics that the Act it says? are those embedded in what you're trying to do and accomplish. That should be standard osmosis.
Okay, great. So I am conscious the chat's been really busy. There's been some really good comments on there and lots of questions. I've gone back and found one. I think we've got time for one more, which I think would be nice to finish on. So we've had a question from somebody just asking whether you can share your top tips for positive experiences of PPI, that you've been involved with. In particular, your tips for students or new researchers in this area. So it'd be great to hear some, positive top tips from you guys and some of your experiences in that. Anybody would like to share?
Okay, I'll go then. I think one of the best quotations I ever had from a consultant who we work with is, doing PPI has taught him how to talk less and listen more. And I think that's advice for life, really, and for PPI. So if researchers go into it with the idea to listen rather than to necessarily talk, then that's a good start.
Okay, great. Andy, did you have your hand up? Or...
No, Liz, you go ahead. I was having a think. Sorry.
Well, a warm welcome. Active listening and use of plain language.
Okay.
So I think having a 2-minute team bubble before they meet the first meet of PPI to say, look, we're welcoming this person into our group as part of, and all that would go a long way. And then, and then thank you and all that at the end, and hope to see you soon kind of thing.
Yeah.
Just plain
Definitely.
charm.
For me to end with, it's this business. I've always said we should not be working in silos, and just being part of PPI groups that I'm involved in. It's amazing how much I'm learning from other people who have other different medical conditions, which I wasn't aware of. And so we've exchanged ideas and thoughts and so on. And they in turn have vice versa. It's been reciprocal. So that is in itself a good thing. You're meeting like-minded people who are into wanting to do research on various other things. That's a positive. You can't work on your own and think, well, you're going to put the world to right on your own. But meeting 6 or 7 other people I'm in one with Laura Chapman, and there's so many things that I've learned since she's on this as well today. I'm bigging you up here, Laura. But the muscle health group, even that, it had a bit different name. Shibabi will write the name in there, because I had to ask the question, what does that mean? Scarpadini or something of the sort. And she said, oh, Tony, based on you, we're changing the name from that, because that doesn't ring any bells with anybody. Muscle wasting, which people straight away will know what you're talking about. So something as simple and basic as that. So it's being able to work with people. That for me is a very, very positive thing. No man or woman is an island. No man or woman stands alone. I'll end there.
Andy, did you have a final point?
Yeah, I've had my thought there. I'm involved, luckily, on 3 clinical areas as well as the research area for PPI. And I think the way that you get the light bulb moment is Kate fetches, if researchers want to come and talk to us about their PPI, and they come and speak to the group, and the group then dissect their patient information, shred it, put it back together and send the researchers away, who afterwards we always wonder, I wonder what they said. And apparently the standard comment is, we would never have thought of that. So it just shows the alter. And I think on the clinical side, I found that the thing that comes to you is when the chair of the meeting sort of phones you up and says, can I add anything that you want to add onto our agenda next time? And I think then you're being listened to. And today, actually, 10 minutes ago, I got a request from another area saying, help, we need patient input with this. Can you be available to help? So, it's having your say. If you've got something to say, then say it. If they don't want to listen to you, then walk away and go and join a group that's interested in what you're going to say and listening. So I think you've got to get that support of, once you get the researcher's ear, I think then hopefully they will take good reports back and say, hey guys, if you want to get this through the committee to do this, that and the other, go and talk to that lot down there. They'll sort you out and put you in the right area. So I think those areas are being accepted, as well as being with a group who can look at things from different ways, is essential.
Great. Well, thank you all of you. It's been a really interesting discussion. There is still lots of comments and questions on the chat. I reassure everyone that we are planning to get all the questions that haven't been answered throughout the whole event to be answered, and we'll circulate those to all the attendees, so you've got the answers to those questions. And we'll also be uploading video recordings of each session onto the Midlands Health Alliance website, which again we will circulate to you once we've uploaded them. I just wanted to thank the panel, all of you, for such a great conversation. Thank you for agreeing to do this for us today, and it's been great to have you, so thank you very much. I also wanted to thank everyone for attending and engaging so much in all of the sessions. It's been really great to hear your opinions and have you put your comments and questions on the chat. And I also want to thank all of our PPIE professionals and contributors that have facilitated the sessions over the last 3 days and helped to plan the event as well over the last few months. And a special thank you to Orange Juice Communications, who have helped to coordinate this whole thing and pull it all together, and for helping me with managing it all, really. So thank you very much, and thank you everybody for attending. It's been really great, and we hope to see you soon and do another event like this in the future. So thank you.
Thank you.
Pleasure. Thanks for organising.
Thank you. Thanks for the.
Can I just say thank
well
you?
done, Lois.
Well done, the organisers. They've done a great job. A bit scary to start with, but it's been superb. Many, many thanks. Enjoyed it. A bit worrying. I enjoyed it. Yeah.
Good.
It was informative and enjoyable.
Great.
Yeah.
I hope we can do it.
Thank you to. Happy to meet you
you.
three as well. Keep up the good work.
Yeah, nice to meet
Indeed,
you all.
indeed.
Yeah.
All right.
Nice to meet you all.
Bye-bye.
Bye bye.